Hello and a warm welcome to all of you attending our press conference for the release of the 5th edition of the TBE book. We are proud to once again present new epidemiological data, namely the 2021 case numbers as provided by local country experts and authorities. Edited again by the editorial quartet, Professor Dr. Gerhard Dobler, Dr. Wilhelm Erber, Dr. Michael Pröker and Professor Dr. Heinz-Josef Schmidt, and written by more than 100 authors, to be precise, 101, covering now 36 countries. So the size of the book grew again a bit, consisting now of 392 pages that present data and research related to tick-borne encephalitis across Europe and Asia. But let me quickly introduce our speakers of today, starting with Professor Dr. Gerhard Dobler. He works as virologist at the University Institute of Microbiology since 2004 and heads the subunit for virology and rickettsiology, as well as the National Consultant Laboratory for Tick-borne Encephalitis. Due to his relevant research results, he's considered nationally and internationally an expert in his field, and we are proud that he is the lead author of the TBE book since the first edition. Professor Dobler will provide us later with an answer to the question, what is TBE and why is it important? Professor Joe Schmidt is co-author of the TBE book and for almost a year now editor-in-chief at Global Health Press. He's a specialist in pediatrics, infectious diseases, microbiology, virology, and epidemiology, and was chairman of the German Vaccination Advice Center, STIKO. Also advisor to the Paul-Ehrlich Institute and various WHO bodies. In 2007, he received the Helmut Stickel Prize from the German Academy for Pediatrics for outstanding achievements in improving vaccine uptake and joined the same year Novartis Vaccines and then Pfizer. Currently, he's strategic and scientific advisor to the EU Commission-funded Baccalaureate European Clinical Trial Consortium at the University of Cologne. He will give us today a short review of the 5th edition of the TBE book. Dr. Michael Pröker is the editor of Global Health Press TBE News, as well as co-author of the TBE book. He has more than 35 years of experience in research and development in various pharmaceutical companies and will explain in his presentation today why we continue to find new areas endemic for TBE. Dr. Wilhelm Erber is as well co-author of the TBE book from the beginning. He's Senior Director, Global Medical Lead, TBE Vaccine at Pfizer, and has more than 30 years of experience in the biopharmaceutical industry. He will present today the most important part of the new edition, the 2021 TBE case numbers and the new TBE map. We are very honored that Professor Robert Steffen is also giving a lecture today, presenting a large number of new data on TBE vaccines. He is Professor Emeritus at the Institute for Epidemiology, Biostatistics and Prevention at the University of Zurich, Switzerland, adjunct professor at the University of Texas School of Public in Houston, and editor of the Journal of Travel Vaccine. So welcome to the presentations.
Welcome to the audience interested in tick-borne encephalitis. I want to give you an introduction. My name is Gerhard Dobler. I'm the head of the laboratory for tick-borne encephalitis in Germany. Tick-borne encephalitis is the most important tick-borne viral disease globally. It causes clinical manifest disease in more than 10,000 patients every year in Europe and Asia, and it is also now detected in Northern Africa. It occurs mainly in the boreal forest zone of the Eurasian landmass, but it is expanding to other vegetational zones like the Mediterranean scrub zone in Southern Europe and Northern Africa, and also to the grass vegetational zone in Central Asia. Tick-borne encephalitis virus is mainly transmitted by ticks of the genus Ixodes, and here especially of the two species Ixodes ricinus and Ixodes persulcatus. A number of countries, however, where the virus occurs also report so-called alimentary infections. That means that TBE virus can also be transmitted by milk and milk products from farm animals like goat, sheep, and cow. And if the untreated milk or milk products are ingested, the TBE virus can cause alimentary route infection. TBE virus is a member of the family Flaviviridae, and it is important to know that it is Flaviviridae, as you can see on the next slide. A number of other important human pathogens are grouped into this viral family, and among them are the dengue viruses, West Nile virus, or also yellow fever virus. And these viruses cause human disease. And as they are closely related to each other, they may cause also diagnostic cross-reactivity, which can make the serological diagnosis of these infections very difficult. In the next slide, you see that we distinguish a number of subtypes of tick-borne encephalitis virus, among them the Far Eastern subtype, a Baikalian subtype, the Siberian subtype, Himalayan subtype, and European subtype. And recently it was recognized that also Lauping-ill virus is closely related to the European subtype and now counts as a subtype of TBE virus. And there is another one, 178-179, which was only one isolated in Russia. But genetically, this is also distinct tick-borne encephalitis virus subtype. Tick-borne encephalitis virus is transmitted within a so-called natural transmission cycle. The virus is transmitted to ticks by viremic rodents like bengal's or yellow-necked field mice, and from tick to tick it is transmitted by transstadial transmission. That means if a tick is infected, it will stay infected the whole life and can transmit the virus as nymph or as adult. And in rare cases, females can transmit the virus to their eggs, so-called transovarial transmission. All other animals like dog, cat, also the farm animals, horses, and also humans are so-called dead-end hosts. That means they can become infected but cannot transmit the virus back to blood-sucking ticks. Tick-borne encephalitis can cause a number of clinical manifestations. The well-known among them are the so-called common clinical manifestations like flu-like disease, meningitis, encephalitis, and myelitis. The last three, the classical diseases of the central nervous system. But recently, the improved diagnostics showed that there are a number of unusual clinical manifestations which may follow also a TBE virus infection, like peripheral neuropathy, facial palsy, autonomic dysfunction of the bowel, polyradiculitis, myositis, uveitis, chorioretinitis, sensorineural deafness, and also myocarditis and pericarditis. And these unusual clinical syndromes should be also intensively tested for tick-borne encephalitis in case that there is any suspicion of TBE infection. This was a short introduction into this important disease. Thank you very much for your interest, and have a nice day and an interesting press conference. Thank you very much.
Hello, everybody. My name is Joe Schmidt. I'm one of the editors of the TBE Book, and I'm happy to introduce to what is new on the 5th edition of the TBE Book. First of all, as in the past, it can be accessed and downloaded free of charge from the Global Health Press website. The book has more than 460 pages by now if it would be printed, but we stopped printing it for cost reasons, but also the demand for printed books is quite low. All chapters have been written by top experts around the globe. We have more than 100 authors, and a great thank you to all our authors who contributed for many years now to the data in the book. The topics that are covered in the book are the history of TBE, a detailed evaluation and documentation of the microbiology of the TBE virus, of the immune responses by the host. We have nice chapters on the natural cycle and of the ticks that are involved of transmitting the disease. The transmission is covered, the pathogenesis of the disease, the phenotypes of the disease in man and in animal. Then we have a nice chapter on TBE in special situations like lactating woman or pregnant woman or immunocompromised host. The epidemiology is updated every year, and that is the bulk of news in this 5th edition. We have all the new data from 2021. Finally, prevention is a big topic. Vaccination and other methods of prevention are nicely covered in the book as in the past. The focus of the 5th edition is certainly the annual updates, and we are proud to say that we're the one in our website and in the book to have the most recent data of TBE from 2021. Thank you very much to everybody who contributed to this, despite COVID and other challenges in public health offices. Thank you for collecting and sending us the data. Finally, the whole TBE book is embedded in the Global Health Press website, which you can access at www.idea.org. And there you will see 9 different topics or big items. That is the TBE book, a vaccinology course. It is video clips, it is news, it is latest science, quite diverse area, all on vaccines and vaccination. Besides having weekly snapshots, we have now a weekly global health cast, and we have a newsletter on TBE. So make your way to the book and have a closer look. Some highlights from the book are, I said already that we have the latest number, but there is one new chapter, and that is on Tunisia. The TBE virus has been isolated in Tunisia, and that will be covered later today. So there is a chapter on that in the book. Each country in Europe and Asia has a different way to find and report TBE cases. Some don't have any surveillance, and then it may look as if there is no TBE, but Michael Bröker will show you in a minute, if you don't look, you don't find it, it doesn't mean it's not there. So how do you assess the TBE risk? What you see here on the left side is the European Centers for Disease Prevention and Control map that gives you incidence estimates for different countries in the European Union on TBE. This map is a challenge. And number one, the data that you see here is 2 years old. The second is old data don't tell you what will happen in the future. And actually, you can say this to our new data. The data in the TBE book are from 2021. What will happen in 2022 is unknown. So estimating the risk or giving an incidence rate is really a little bit, misleading, because, for example, in the Baltic states, there was a logfold difference in different time periods for TBE, and that is not shown here in this map at all. The impact of vaccination is not shown. The completeness of reporting is not shown. Many countries are not included, particularly Switzerland is not part of the European Union, so they are not covered here. And then we have these Southeastern European countries, and I'm not sure, I guess France is not covered here, or it is yellow only as Italy and Greece. For Greece, I have not seen a well-confirmed case on TBE, but on France, there are TBE cases, and there are even milk outbreaks, as you will hear later on. So that should not be yellow at all, but there is no data on it, right? So this map is a challenge, but then how can you, give a risk estimate? And what we think, and what we have now implemented in the book, is that any area where the chances of transmission of an arbovirus to humans is above 0, that is called a risk area. And that is what we have in our book now. We have used the ECDC definition of arbovirus infections for TBE, which is an arbovirus. And the background again is that the actual risk cannot be quantified. So what we do is we label countries if they are predisposed, and predisposed means the climate and the landscape are in a way that the TBE virus may be present, but it has not been shown. Imperiled means the TBE virus has been documented. Affected means human cases have been documented. Endemic means that human cases recur annually. So this is now our definition of countries. Countries may be predisposed, imperiled, affected, or endemic, and that is another way the European Centers of Disease Control quantifies the risk, so to speak, for TBE virus infections in that case here. Congratulations to our IT colleagues at Global Health Press in Singapore for having a map now that goes down to county level for each country to show you if a country is a TBE risk county. We also would like to thank our publisher, Daniela Lamarca, who made this all happen again in no time. And thank you again for your excellent team and the wonderful collaboration with your team in Singapore. Thank you.
My name is Michael Bröker. I'm co-editor of the TBE Book. During the next 7 or 8 minutes, I would like to discuss with you a phenomenon which I have named, if you don't search for TBE, you will not find it. In Central Europe, but also in Sweden and the Baltic countries, the surveillance and reporting system for TBE are quite good, although not optimal. But in many other countries, surveillance and reporting are insufficient or are totally absent. And this is also true for the United Kingdom. Until recently, the UK was thought to be free of circulating TBE virus. But intensive analysis of patients with meningoencephalitis cases revealed 2 probable cases. And this is marked with a C and D in the southern part of England. In addition, zero epidemiological data in deer confirmed circulation of TBE virus in England. See the red area. And third, TBE virus has been detected in ticks found at places A and B. The Netherlands were assessed TBE-free until 2016, when the first TBE cases were reported. And since then, new cases have been reported each year. The Netherlands is now confirmed a TBE endemic country. You see in the slide the orange dots, that is where TBE virus has been found in ticks, and the gray areas are showing where ill patients have been reported. A similar picture was seen in Belgium, which was also assessed TBE-free, but the first case has been reported in 2020. This is marked in the slide with the 3 dots. Circulation of TBE virus in Belgium is confirmed by zero epidemiological studies in wild animals, and positive areas are marked in gray. France is a country where TBE is rarely reported, mostly in the eastern regions of the country, in the Alsace and in the Rhône-Alpes region. Only a few laboratories carry out TBE diagnostics. Recently, an outbreak in a region considered TBE-free to date, the department of Ain, occurred through consumption of cheese from unpasteurized goat milk, and more than 40 individuals were affected and became ill. Next slide, please. Last but not least, TBE virus was shown to be circulating in northwestern Tunisia. Migrating birds may import TBE virus infected ticks from Europe to northern Africa. You may be surprised that TBE virus is also circulating in Africa, but please consider the northwestern region of Tunisia is relatively humid and has a similar Mediterranean climate as other Mediterranean European countries where TBE is endemic, like Serbia, Croatia, or Albania. So what are my conclusions? Many countries in Europe and Asia have no or only an incomplete surveillance and reporting for TBE and for the TBE virus. In many countries, routine diagnostic tools to detect TBE cases are not even available, or they are not used. In Asia, this is true, for example, for Japan, South Korea, and China. And in Europe, that's Poland, France, and mostly in the Eastern European countries. Many countries will report new isolation of the TBE virus and or of TBE cases in the coming years. This is not only the result of climate changes, but a result of inappropriate surveillance. And having said that, we are back to the title of my contribution. If you don't search for TBE, you will not find it.
Ladies and gentlemen, my name is Wilhelm Erber, and I'm requested to present you in brief some objectives of the chapter 12 of our new edition of the TBE Book 22. As you know, TBE is a communicable disease in the EU since 2012. However, implementation of the reporting system is done on a national level only, and the surveillance system in each country is very different, and in terms of quality and quantity. You know that a regular use of TBE serology in detecting TBE diseases in patients with ZNS affection is done in very few countries only within Europe. A scientifically appropriate method, however, would be to document at least 80% of all subjects with ZNS disease to test against TBE in an endemic region. However, this is not the case in any of the countries, so the numbers we are summarizing in our book cannot be directly compared, and there may be a huge bulk of underreporting. So the numbers you see and find in a very comprehensive list in chapter 12a runs over many years, runs over quite a lot of European countries, most of the European and also Asian countries. However, this is only the tip of the iceberg. And what we are doing, therefore, is to not to present TBE endemicity in terms as a quantitative issue, not to speak about incidences, just in order to show the audience where TBE cases occur, where the virus occurs in nature or in some sentinel animals. So this is then the brand new map we are producing and presenting in the new edition. This map drills down to county level in each and every country. So in some way it looks somehow scattered, as here in China or in Germany also, but this is the true reported cases in the counties. What you see here basically, TBE cases have been reported, and endemic areas have been reported from England to the Far East, to Japan, to South Korea, to China, and even southbound of the Mediterranean Sea in Tunisia. We have recently found the virus circulating in nature. So in summary, the TBE virus has a broad circulation throughout the Eurasian continent, even south to Tunisia, and the reported TBE cases are summarized in the book, representing only the tip of the iceberg. The TBE map, although looking somehow scattered, drills down now to county level as it is reported by the respective countries, and this may help physicians but also travelers searching for information on TBE before traveling to Europe and Asia. Thank you so much.
Good day. Pleasure to contribute to these updates in the global health press. Actually, as probably most among you are aware, there are 2 vaccines available in the Western world against tick-borne encephalitis, and essentially both are pretty similar. With respect to the doses needed, as illustrated on this picture, you realize that the primary vaccination course consists of 3 doses, this with minimal differences. And thereafter, depending on the dose number and the age of the vaccinee, the boosters are indicated every 3 or 5 years. And that actually means that there are more frequent boosters as compared to any other vaccine in the Western world. There is evidence that this results in low compliance with the TBE vaccination recommendations and also with a low overall acceptance of this vaccine. The public simply doesn't like so many doses. Frustrated about the low vaccination compliance in Switzerland, the Federal Office of Public Health already in the year 2006 recommended that boosters should be given only every 10 years. And now, more than 15 years later, we have evaluated the situation, and I can give you some good news. Actually, the Federal Office of Public Health evaluated the vaccination failures first in the initial 3 years after primary vaccination, and then in the subsequent 7 years, which totals then, of course, to 10 years. And as you can see, the number of vaccination failures in the second period does not increase at all, which illustrates that actually protection is far longer than the 3 or 5 years when boosters are requested in the other countries. Actually, it is assured that boosters every 10 years are absolutely sufficient according to this review by the Federal Office of Public Health. Actually, additionally to this evaluation by the Federal Office of Public Health, a second analysis has been conducted in Switzerland in the form of a case control study. And here in this summary, you can immediately realize that the vaccination effectiveness does not decrease at all if you prolong the period of time since the last vaccine dose, and thus the protection is not only 10 years probably, but it may also be longer, as documented in this study, which has not yet been confirmed by additional data. Next slide, please. Thus, there is additional evidence for long-term protection by the TBE vaccines. It has been confirmed now by 2 studies for 10 years and by one study for even longer. As demonstrated on the initial slide, the TBE vaccination schedules are truly cumbersome, and they are solely based on historical serological data. And this is a narrow-minded approach. Nowadays, we have learned, particularly also from assessment with COVID-19 vaccines, that serology data are insufficient with respect to vaccine effectiveness. We also need to consider cell-mediated immunity. And as demonstrated by two studies, the current effectiveness data from Switzerland, and actually there are additional data also from Austria and Latvia, they indicate that the 2+1 schedule for primary immunization with subsequent boosters every 10 years induces a high and long-term protection rate. And thus, I would strongly recommend simplification of the tick-borne encephalitis vaccination schedules, as mentioned, 2+1 for primary immunization, followed by 10-year boosters, because then there will be a public health benefit by increase in the vaccination uptake and compliance. Thank you very much.
Thank you very much to all the presenters of today. Thank you to Daniela Lamarca and your team in Singapore for setting this all up. All materials will be available online for download later on. We also have prepared abstracts in German and in English so that you can use them as you need them. The floor is open for any questions. You can write them in the chat, or maybe you can even open your microphone, and then whoever is first can ask the question. And maybe I start with asking, before people warm up a little bit for more questions, I start with asking Gerhard Dobler the first question. Gerhard, I always thought that in Europe it is not legal to sell unpasteurized milk. Would you have any knowledge on the situation there? And we have milk outbreak, dairy outbreaks in Germany as well, right?
I'm just fighting. I'm here. I'm just fighting with the techniques, but I hope you can see me now.
We can hear you. Go ahead.
Regarding your question, yes, officially it is not allowed to sell unpasteurized or untreated milk. However, we have now what we call this places where milk is sold directly from the farm, and the farm just informs the consumer that they should not drink this raw milk without treatment. But of course, this is usually not followed by the consumer. And what we also know and hear very often is that especially goat milk does not taste very well if pasteurized. So goat milk is mainly consumed unpasteurized, and most of the cases we see in Germany are caused by goat milk.
Thank you, Gerhard. And one more question. What is quite amazing, after knowing about TBE for decades, now all of a sudden there are diseases out there that are outside the CNS. This is quite a surprise. So my question to you, a little bit provocative: if I have diarrhea after a tick bite, or after visiting or traveling to a TBE endemic area, should I, as someone with diarrhea, get tested for TBE?
What we see during the last years is that many more symptoms are associated with tick-borne encephalitis infection than we thought before. So I would not recommend to test every diarrhea against TBE. However, if there is a clear medical history, that means you had 1 or 2 weeks before a tick bite,
you have now diarrhea, and all other common causes are excluded. Then, of course, you also could test for TBE, but in these unusual clinical symptoms, TBE should not be the first front diagnosis, but only if other common causes are excluded.
Thank you for the answer. Again, if anybody else has an answer, go ahead and ask your question or put it in the chat. And as long as nobody jumps in, I continue with my questions now for Michael Bröker. Michael, there are reports on TBE from Greece, but in the book, Greece is not in the countries that that have TBE virus. What is the difference between Greece and Tunisia?
Well, there's a difference. We have discussed very often if Greece may be an affected area. The point is, as already Professor Gerhard Dobler has pointed out in his lecture, that there are similarities between the various flaviviruses. And if you use a test which is not specific for TBE, it might happen that you measure antigens of another flavivirus. In Greece, for example, the Greek goat encephalitis virus is endemic. And it might have happened that the authors who have published data about TBE in Greece have used a test which was not specific enough to unequivocally say it was TBE. There are similar examples for Spain and Turkey and even for Kenya. There are publications that the authors say they have measured TBE antibodies in animals or humans, but the tests were not specific enough. So we would say there is a probability, a high probability, that TBE virus is also circulating in Greece. But so far, it has not unequivocally shown that there are really TBE cases in humans.
Michael, thank you very much for this answer. So it has to do with documentation of the virus in the country, which we have for Tunisia, but we don't have it with certainty from Greece. That is the point, right?
Yes, that it is.
Yeah. I see one question online, and maybe I ask you, Michael, and then maybe Robert, Steffen, who is also on the line, this question or your personal views. The question is, my understanding is that there is no effective treatment against TBE. Why would you consider even testing for TBE if it doesn't matter? In the end, you cannot do anything. Michael, what would be your answer?
You can do something. There are indications that you must treat the patients. And if you know that it is TBE, you can handle appropriately. For example, it is not generally recommended to use certain compounds, but you see, just some days ago, I was asked by physicians of the University of Marburg. They have a severe case of TBE, and they asked me for, is there any treatment available? And I answered, no, there is no treatment available, but there are experimental data for a drug which is called favipiravir. There's one publication that this drug has helped one patient in Austria. So they discuss now if they use this experimental treatment.
Thank you, Michael. And to Gerhard, I think there are quite a number of drugs that are active against the TBE virus in vitro, but none of them has really been studied. Do you know more about this, or can you tell us a little bit about it?
Yes, there are some experimental drugs, but so far which are effective in experimental models, However, the point is the effectivity in cell culture in an experimental model is one thing. The other thing is this substance has to be non-toxic for the patient, which is already difficult. The other point is the substance has to be distributed in the place of infection in the body. That means in the case of tick-borne encephalitis, the substance has to penetrate the blood-brain barrier and enter the brain to be effective there. And so far, none of the studies in experimental settings fulfill all these conditions to become candidates for a clinical study. And by the way, there is at the moment no flaviviral infection which can be treated with medicaments, also West Nile and dengue and yellow fever. We do not have any treatment for these flavivirus infections at the moment.
Thank you for your answers. So number one, there are, let me say, experimental treatments out there. That would be one answer. And Michael embarked on this one that looked really promising in this one case, and Gerhard had some more. I think there is one other reason to have good surveillance for infectious diseases. And the reason is really, if you don't know what makes people sick, you cannot do anything against it in the future. Without knowing about the burden of disease, there would be no vaccine, there would be no drug development, and nobody would even care. Somebody dies and it was TBE, and who cares about it? I think this is a wrong approach, and it is a non-medical approach. I think it is the ethical obligation of physicians to diagnose what is the cause of the disease, and not just to treat and not to know what is happening with the patient. I think this is a very principled medical point of view that I have. That is the way I was educated. I was, as a student, really always asked, what is the organism? And later on, I was practicing infectious diseases at a cancer hospital in New York. And I can tell you, if you don't know what is causing the infection in a cancer patient, they will die. You cannot do the right thing. And if you're blind, you don't know what is going on, and it will result in wrong treatment. In any event, I think we have many good answers for the questions, but maybe there are more questions. And until they pop up here in the chat, I will ask Willi. Willi, looking at your map, I saw that most of Germany is not colored. So can I safely travel? Actually, I'm here in south of the Mainz, southwest of Frankfurt, south of Mainz area, and it is not colored. Will I get TBE when I go to nature out here and I have a tick bite?
Well, definitely we don't know, but it is probably indeed, because the German PI definitely focuses on a very sophisticated grading of risk, and they especially the southern area of Germany is Bavaria, Baden-Württemberg, for example, is an area where it is said to be human cases on regular terms. Specified by the PI. The northern area of Germany only has scattered counties where single cases here and there occurred. But as already said, if you don't look at it, you won't find it. And yeah, what we can show in the map only for Germany and for the rest of the world is retrospectively where the virus has been isolated, retrospectively where human cases have been occurred, but no clue on what will happen tomorrow and the day after.
Mm-hmm. Willi, in the TBE book, you have your eternal list of TBE cases from most countries that are known to carry the TBE virus. This is a very impressive list. It is really comprehensive, and you have been entering the numbers for decades now. So this is a great piece of work. It's always enjoyable. But following the discussion that we had so far and looking at the more detailed data in the book, if the numbers are not reliable, why do you have this list? I mean, just make it black or white, there is or there is not.
Yeah. I could easily say it is for academic reasons. However, it still gives us some clue about long-term trends in Europe and Asia. And yes, you're right. Observations or the surveillance may vary. Let's say comparing 2000 to 2022. Yeah. However, it is also as we assume an increase in risk areas due to reasons whatsoever, and yeah. So just for this case, I would say the case number table is a reliable source of information.
Yeah, so thank you, Willi, and I hope you continue this work for a very long time. So I also think it is important. The numbers are not the true picture in the end, but depending on definitions, completeness of testing, everything that was discussed today. But in the end, you may have a look at trends, and I know that Gerhard depicted some nice trends, and we can discuss this at another time. But thank you, Willi. Robert, I was very interested in this recommendation in Switzerland. You recommended very courageously, or your government officials in this case, they very courageously recommended all serology is stupid. We go for effectiveness and we go for memory cells, and I don't know what their thinking was. But in the end, explain me, why were they courageous? Why did they change the booster from 3 to 10 years?
Thank you for that question, Joe. Actually, as I mentioned, we were truly frustrated because even in the areas with the highest endemicity, vaccination coverage was less than 20% before 2006. And we did have some, let me be honest, weak data that protection might be longer, actually basing at the time only on serological evidence. And so at the time I was the chair of that subcommittee, we decided, as you say, very courageously to prolong the intervals for boosters. And that had a tremendous effect with respect to the vaccination coverage in the way that before that recommendation, we used less than 200,000 vaccine doses in the entire country. And in 2006, that raised to over 1 million, and thereafter stabilized much higher as compared to the pre-recommendation period. So we actually argued at the time that we would prefer a maybe 92% vaccine effectiveness to a 95% vaccine effectiveness if a much larger proportion of the population would accept vaccination. And actually, that result has been achieved. And second, actually, we can now look back and we can argue with strong evidence that the decision was correct.
That is great news from your country. I understand also that in a similar way, but not quite as courageous as you did, Finland also went now for 10-year boosters. And we can discuss this at a later point. My question is, looking at your data, it looks as if a longer time interval between booster doses even gives you a significant higher effectiveness, from 91 to 98%, if I remember correctly, and the 95% confident intervals don't overlap. So this is likely a significant difference. Would you have any explanation for that, or what do you make of that?
Actually, you truly have sharp eyes, Joe, noticing that. And I agree that this would be a significant result. However, from this single study, I would not yet conclude that the vaccine effectiveness increases the longer you wait, because that is not really plausible biologically. But we need additional evidence, we need additional data to determine whether really that might be a fact, and thereafter we'll need some explanations.
Thank you very much, Robert. I think we covered quite a few questions by now. I don't see any questions online, and unless someone is jumping in now with a question, I just would like to give you the information that all materials we presented today can be downloaded. We also prepared abstracts. You can download them in Word or as a PDF file. And you can see all the clips, all the presentations individually, or you can see the full clip later today. It first has to be, I guess, prepared, downloaded, and then put on the website. So that may take an hour or so. But all materials will be available. And again, if you go to the GHP website, you will also be able to download the full new TBE book, play with a new map and look at the different geographical areas down to county level. And you can also register for receiving the snapshots that Michael Bröker presents in a regular, I guess, once a week, and a newsletter once a month in a very regular way. Having said this, and with no questions in sight, I thank everybody for attending. I thank all the presenters, authors, and editors of the TBE book, and certainly our publisher and her wonderful team in Singapore. Thank you very much and have a nice day. Bye-bye.
Thank you so much. Bye.
A big thank you to our speakers today and to all of you for making the time. The TBE book is available for free at www.tbenews.com/TBE, thanks to Pfizer sponsorship. And finally, I would like to point out that unlike other publications, the authors of the individual chapters are the copyright holders and bear sole responsibility for the respective content. All of today's presentation, as well as the abstracts and CVs of our speakers, can be found at our website, /MediaKit. And thanks again to all of you. And if there are any questions, please feel free to contact us directly at mediabuzz@globalhealthpress.org. Bye-bye.